Great to be here in California. It feels like home, actually. My sister lives here, so I'm very happy. I'd like to start by actually asking, here's the first slide. How many people have heard about low FODMAP diet here? Oh, great. How many people use it in their clinical practice? Fewer. How many work with a gastroenterologist who actively refers patients to them? Fewer again. But better, in Michigan, we were there last week and there was only one dietitian who worked with a gastroenterologist. That was out of 270 dietitians. I think that, we really have to work hard at this. In Australia, a GI gastroenterologist would never have, they would always have a dietitian. And Peter says, who's been a fantastic advocate for dietetics, how can you practice GI or be a gastroenterologist without a dietitian? So I think it's something we have to really work at. This is a strong evidence-based diet. It's a fantastic area for dietetics, so I hope you get involved, and we're here to help, and that's why we're here. So let's get on with an overview of how we put this diet into practice. So today I'm going to talk a little bit about the low FODMAP diet, just briefly the criteria of how we describe what is low, something about the dietetic management of IBS, and also some case study examples. Is that making a sound? Is that okay? Now, don't worry, we will leave these slides with Bridget. Where are you, Bridget? Because there's a lot of information here. You don't need to write everything down, so don't panic, okay? And we're here in our booth, and please come and talk to us if you'd like to. We're here for the next few days. Sorry, that's doing that. I don't know. I'm not touching anything. Okay, so let's talk about the low FODMAP criteria. As Peter said, these FODMAP sugars are found widely in our food. They're everywhere. And we've been actively measuring them in food for over 12 years now. We've been building up this huge database of FODMAPs in foods. We defined a cut-off level, what we define as low FODMAP. We did that based on our own clinical work, and we used these cut-offs in our dietary studies and our clinical studies. So they're well evidence-based cut-off levels. So we define what is low, and we've actually published that paper if anyone is interested in looking that up. When you look at FODMAP, different types of FODMAPs that are in food, you can see here from this diagram, sorry, I'll go over here. I don't know if that's better to go over here. But you see that foods contain different amounts, different types of FODMAPs. And when you apply the cut-off levels, you can see that it can easily divide food into, each category of food has high and low FODMAP choices, if you like. So you can go down and for bread, for example, there's obviously rye bread is very high in FODMAP, but you have low FODMAP choices, if you like. And each food group has this. So by measuring and understanding what is in food, you can choose a low food alternative to a high FODMAP food. So it's really making these choices. It's not really restricting your diet, it's really replacing a low FODMAP alternative, taking out the high FODMAP food. And of course, we deliver all of our knowledge about FODMAP composition through our smartphone application here. And I saw a young fellow here looking at it. Download it. Did you download it? You were looking at the app. Download it. It's great, yeah. So I've caught you out there. So basically the diet it's a balanced diet. There is no food group that is excluded. It's a nutritionally balanced diet, which is what we all like to hear. Okay, so dietetic management of IBS. As Peter alluded to, there are 3 important phases to this diet. The first one, phase 1, is this low FODMAP phase, which goes for about 2 to 6 weeks. So it's important to remember with your patients, this is not a lifelong diet. It's not like gluten-free for celiac disease. This is a learning diet. This is all about you helping your patient learn which are their FODMAP triggers and where they're found in their diet so that they can go away and really manage their condition. So it's a learning diet. We start off with this strict phase because we want them to get well fairly quickly. Then we have a second phase, which is the reintroduction. That's the real learning part of it. And the final phase is this personalised phase. So there's 3 phases. And I'm going to go through each one now. So the first phase, the low FODMAP phase, is really aimed to induce symptom control. We want people to feel better quickly. We want them to feel confident that you know what you're talking about, and they're going to come back and see you because you've found the answer. A lot of these patients have been going from doctor to naturopath for years, often decades, trying to find a solution to their problem. And we want them to feel that you've got the answer. We want to know if this is the answer to their problem, and they'll come back to you. So we restrict it for 2 to 6 weeks, and your role really is to do your normal clinical assessment and look for red flags. Now, Peter didn't talk about red flags. Peter forgot to talk about the red flags or your alarm features, which is basically, if they haven't been properly diagnosed, you'd want to send them back to their doctor. So make sure celiac disease is excluded. There's no signs that there might be something more sinister going on. And we can talk a bit more about that in discussion. But look for red flags. Do your dietary assessment and make sure that you've got to determine, I guess, the level of restriction that they might require. Now, if someone's presenting and you can sense that they've had eating disorders, that would be a strong contraindication. You would not embark on a strict diet with that individual. So it's really up to you to use your skills to decide when this diet and how strict this diet should be implemented with the patient. For some, you would not even mention the word FODMAP. You just simply try and modify their diet as much as you can. For children, you'd have a different approach as well. Of course, as part of your education, you're going to use all the normal things we do as a dietitian, looking at their diet, hopefully explain the app, how that can help them navigate the diet, recipes, menus, and how they can adapt their diet to follow this just for the first 2 to 6 weeks. Now, phase 2 is this reintroduction phase. This can go for 6 to 8 weeks, and this is probably the area we get most questions about. The aim really is to identify the individual FODMAP subgroups, which are a problem for that patient. And because everyone is different, you have to do it. It's sort of, there's no black and white answer to this. It really is a case-by-case sort of basis. So why do we want to introduce? Well, of course, as Peter said, some FODMAPs are prebiotic carbohydrates, the FOS and the fructans, galacto-oligosaccharides. We don't really want to over-restrict these because these are probably quite important for our gut microbiota. So we want to make sure we're reintroducing as much of these as people can possibly handle. So that's one reason why. We want to make sure people have a diverse diet, that their diet is nutritionally adequate, and we don't really want to exclude foods if they don't have to be limited. Improving the variety. And I think it's also the patient learn so much about which are their particular trigger carbohydrates and where those are found in their food. So as I said, it's a powerful learning tool, and there's a publication there that may help. So phase 2, this reintroduction phase. So what does the dietitian do? You really have to identify when best to start. And often that's when the symptoms are well controlled, of course. And the patient has to be ready. And this is often, you have to negotiate this because often you find patients are feeling so well after so long of not feeling well, they're reluctant to introduce or change anything. So it's quite a bit of negotiation that has to go on. But it's important, I think, using the example of the prebiotics is actually quite a good way of encouraging them how important it is that we try and get more of these into your diet because they might be important for your gut microbiota, and everyone seems to be interested in that. Might be a little way that you can encourage them to explore and try introducing more FODMAPs back into the diet. They have to make sure that they have adequately tested the diet, of course, as well. We have to interpret the response to the diet and troubleshoot, I guess, if they haven't responded very well. And really you have to tailor the reintroduction program to suit your particular patient, and it's often which foods they've often missed. Ensure that their diet is adequate, nutritionally adequate. So the phase 2 of the diet, this reintroduction phase, as Peter was saying, there are these different FODMAP groups, and you need to, I'm going to go back. So each one has to be brought in one at a time, While their background diet is low in FODMAP, so it's just one subgroup at a time, not all of them at once, to work out which is the particular problem sugar, and you're bringing them in the form of the food that they're found in. So for example, here's a table of FODMAPs here. So for example, for excess fructose, we might use honey and mango. For lactose, of course, you use milk, sorbitol, avocado, apricot, mannitol, mushrooms, cauliflower, particularly rich in mannitol, and fructose and sorbitol, you use an apple or pear. So this is, you're finding a food source that naturally has these FODMAP subgroups in them, and you're introducing them a small amount over about a 3-day period, and you can increase the dose. You often ask the patient which food that they've really missed, and that's often where you'll start. And you often negotiate also. If they never ever eat avocado, well, you wouldn't use avocado, for example. So you find a food that they're missing that also has a subgroup in it that they need to test. So there's also, of course, fructans. We might use wheat. We also use onion, and GOS, of course, we use legumes. I often ask them, teach the patients to come up with their own food challenge, and that's very empowering for them as well. So that's phase 2, the reintroduction. So there's no one size fits all, so that's why your role is so vital. This is not something that a gastroenterologist is going to have time, no one's going to have time to do this. This is your role. It takes some time to do this, some skill, and that's your skill. And it really is up to you to negotiate and work with your patient because it's so individual. Everyone is different. So this is why it's so vital for us to have a role in this diet. So we usually have a 2 to 3 day washout between each of the challenges, so things can settle down. So basically it takes about 6 to 8 weeks to go through all of these challenges. So the final phase is this personalised phase, which is really, you're basically, the role of it is to reinterpret all of that challenging. You've reintroduced as much of the FODMAPs back into the diet that they can tolerate, and really you're personalising it to them. And we basically want to tailor the diet for that individual. And you're wanting them also to have the courage to keep trialling and testing their own tolerance. And they really need to have as much of the FODMAPs back in their diets they could possibly tolerate, and keep on challenging themselves. So you're giving them the skills that they can go away and manage it. Sometimes symptoms are not fully resolved with diet, and this is where other therapies can come in. So basically they need to learn to self-manage their own symptoms. If they have a relapse, so they've accidentally gone out and eaten something, they've had terrible pain the next day, they actually understand what it was they ate, and then they're going to be fine. They'll be fine the next day. So its knowledge is terribly powerful. So keep going, introducing. So I've got a case study here of Sarah. Now Sarah is a 28-year-old female. She's been suffering with bloating, wind and diarrhoea. And the symptoms are present for most days and usually worse at the end of the day. Now her medical doctor visit results in negative for celiac disease, and there's no micronutrient deficiencies, doesn't seem to be anything abnormal there. The doctor trialled a lactose-free diet, wasn't very successful, and so now she's come to you. And the problem really is she does have some stress over the last few months, and this is a very typical kind of scenario that we see a lot. So what you do, of course, you do your diet history, and this is Sarah's diet, typical daily intake. So you look for breakfast here. We've got a raisin bran cereal. You're thinking, okay, well, there's going to be a lot of fructans there in the raisin bran, and also in the raisins. Pear, high in sorbitol, fructose. There's apple for morning tea, high in fructose, sorbitol. At lunchtime might be a sandwich. Again, high fructan sauce, ranch dressing, which is going to be onion, garlic, salts and things there, high fructans again. Or a burger, again, high fructans in the burger bun. Enchiladas, which I understand will have onion in there, yes. Sorry, yes, I'm just learning. The dip will have, dips will certainly have onion and garlic. You're thinking onion, garlic. Chili con carne, which will have legumes, will have beans and onion and garlic. Gravy, which will have, again, often onion, garlic, salts. And pasta, again, fructans. And the sauce, of course, often with onion and garlic. So Sarah's diet is loaded with FODMAPs, and you think, okay, well, we could make some changes here. So you teach Sarah about the low FODMAP diet. She comes back to you, and she returns. She's doing the first phase. We're doing phase 1, first 2 to 6 weeks, and she's really happy. You know, she's had 90% improvement, thinks you're wonderful. So she really, she does still, we have to question her. Some of her reports, though, she does still get a small amount of gas. And what do you advise when you hear that? You say, well, a small amount of gas is normal, don't worry. And you have to remind people that it's just part of normal physiology, you know, the bacteria doing their thing down there. So that's okay. People need to hear that because some people forget. They forget. So that's all normal. She's been able to follow the diet fairly well, but she has had trouble removing all that wheat that she seems to eat and all that garlic and the onion. She's found that difficult because she eats out a lot. So what is your next management plan? You start the reintroduction phase. As we're going to phase 2 now. So it's one food at a time, remember. We ask her what she's been missing most and what's the biggest problem for her. You leave 2 to 3 days between each food challenge. You keep avoiding the FODMAPs until you work out the tolerance level, and you monitor symptoms closely. We actually get them to keep a little diary, and this is a sort of this is what you've worked out with Sarah as her challenges, really, to go back over the next 6 to 8 weeks and work out one at a time these sorts of challenges that she would be doing. So for onion, she seems to be missing that. You might try, let's try 1 onion wing over 3 days and monitor your symptoms. And you go through that. So it really is them recording what they're doing and how they're feeling. So basically, Sarah she's finished the challenge. She finds the following are the main triggers for her, which is onion in large quantities, mannitol and lactose. So your long-term management plan is really encouraging her to reintroduce all those foods that she should tolerate well. And we remind them again about the importance of the prebiotics, and so to get those back into the diet as much as she can tolerate. And you encourage the ongoing testing, really, of the onion and the mannitol. So, and it's basically finding that level of tolerance. If they understand that it's just simply a dose effect, so it's probably having less of something that they enjoy rather than having large amounts. And it's okay to have a relapse. It's okay because the next day you'll be fine. You know exactly what happened. So again, it's a very powerful learning tool. And stress is often a trigger in this, and sometimes we need to go to another level to help people stress, and that's where hypnotherapy and other strategies can be useful for these patients. A common problem we find with people like Sarah is getting enough fibre in their diet. So we really have to work hard at that. Of course, we've got to encourage the low FODMAP sources of fibre, which is the fruits and vegetables that are low FODMAP, and also including some fibres such as, there's linseed, chia, rice bran, oat bran, which are low FODMAP, encouraging those. It can still be quite tricky to get the fibre in, and if they have too much, of course, they can trigger symptoms. You can use fibre supplements also in these patients, and we do that with ours. And psyllium husk has been used, but some people find it triggers bloating, so just be careful of that. You need to try and go for a low FODMAP fibre supplement that is one that is also not rapidly fermented, the sort of the slowly fermentable ones, which is methylcellulose, sterochlor, and the PHDG. And of course we have a little certification program, so we actually are testing not only just foods but also fibre supplements to identify those that would be low FODMAP and possibly suitable. And we're very pleased to see Regular Girl here and Sunfiber, and they are low FODMAP, so they're certainly something you can explore with your patients, and they have a booth here, so go in and check them out. Other areas where the low FODMAP diet is being used, it's very interesting to see this diet being used in other areas around the world, and it's very exciting. Children with IBS, it's being used there, and there's some quite nice evidence around that. It's been used for endurance athletes to control gut symptoms associated with their events. It's also been used, beautiful work done by our own Marina here on colic, controlling colic in infants who are breastfed. It's been used with patients who've got inflammatory bowel disease and associated IBS, so it's been used in that area as well. Women with endometriosis who also have IBS symptoms are using the diet. It's also used to control post-infective IBS, which is associated with gastroenteritis, and individuals who are on the gluten-free diet. And I could spend another hour talking about that, but I haven't got time. But basically, these people benefit enormously from the low FODMAP diet as well. So just in summary, so here we have management, IBS patients, low FODMAP diet for 2 to 6 weeks, and followed by symptoms, I'm having trouble reading that, improvement, so they have improvement. Then they'll go on to the second phase and the third phase, as we've talked about. If they have no improvement, though, as Peter said, you have to be sure they've tried the diet, but you take them, if you're certified that they actually did try it properly, you would then take them off the diet. You won't leave them on a diet that's not working for them. So that's important to remember. And if there's no improvement at all, you can explore other, all the FODMAPs come back into the diet, and you can explore other strategies such as hypnotherapy, cognitive behaviour therapy. So I think that's where you need other allied health support around you. So take-home messages: a proper diagnosis of IBS is essential, and that really needs to be done by a medical practitioner. The low FODMAP diet is a very effective diet strategy, and it works for 75% of patients, so it's better than any drug that's out there. There is this 3-phase program, so it's not just putting people on a low FODMAP diet and leaving them there. It really is this learning diet, if you like. Follow the 3 phases, and they end up with a personalised diet for them. And basically, if the diet's not working, you really need to look at other management therapies with them. Now, Monash has developed a lot of a toolkit, if you like, to help with delivering this diet, and there's all sorts of things. We have, of course, the app, but we have little booklets, certification program, and just last year we released an online training course. So if you're interested in this area, you might be interested in doing that. And we have got little cards at our booth here, so please come and talk to us, and we'll happy to discuss that with you. And I'd like to acknowledge my team, our team, Peter and me. It's been fantastic. All this work has been really the result of a lot of people working together. We have, doctors, scientists, dietitians, nurses, all sorts of people working together, and it's been terrific for us, very rewarding area for us, and it's very rewarding for the patient as well, because they have finally a solution to their problem. So please join our community if you're interested in social media. We have a very active Facebook, Twitter, and we have a website there.